Hey everyone, and welcome. Today, we're going to cackle some of the most advanced and, let's be real, sometimes pretty intimidating modes in mechanical ventilation. Our mission is to pull back the curtain, demystify how they actually work and really get to the why behind them. All right, let's just jump right in. Everything in mechanical ventilation really boils down to one fundamental choice. Are we controlling the amount of air, the volume, that goes in with each breath? Or are we controlling the force, the pressure, that we're using to deliver that breath? This one question, this is the core conflict, and it's the reason all these fascinating advanced modes were even invented. So before we can even get to the cool advanced stuff, we really have to master this core dilemma. Think of it like a constant tug of war, a battle of physics that's happening between the machine and the patient's own lungs with every single breath. And the referee in this whole tug of war? It's a concept called lung compliance. Honestly, the easiest way to think about it is just stretchiness. Healthy lungs, they're nice and compliant. They inflate super easily. But sick lungs, like an ARDS, that's acute respiratory distress syndrome, they can get incredibly stiff and non-compliant. And all of a sudden, they are way, way harder to ventilate. Okay, so this lays out the two classic strategies for dealing with that lung compliance. With volume control, you're basically telling the vent, look, I don't care how hard you have to push, you are going to deliver 500 milliliters of air. The pressure, that's what changes. But with pressure control, you do the total opposite. You say, hey, push with a nice gentle pressure of 20 and do not go higher. And what happens? The volume the patient actually gets is now the variable, and it totally depends on how stretchy their lungs are in that moment. And this is just a brilliant way to think about the basic physics here. It's so intuitive, right? To get more volume into a container, whether it's a balloon or a lung, you have to use more pressure. This simple, unbreakable rule is the foundation that every single ventilator mode has to obey. So you've got this constant trade-off. Guarantee the volume and risk high pressure, or guarantee the pressure and risk low volume. But what if? What if a machine could intelligently try to give you the best of both? Well, that's where our first advanced mode comes in. Let's talk about PRVC, the Smart Optimizer. So, here's the big idea. PRVC, or Pressure Regulated Volume Control, it wants to give you that gentle, decelerating flow of a pressure-controlled breath, which, by the way, is usually more comfortable for the patient, while also making dead sure they get the exact tidal volume you've ordered. It's a true hybrid, and it's designed for stability. So, how does it pull this off? Well, it's constantly learning. The ventilator gives a tiny little test breath just to size up the lungs. Then it makes its best guess for the pressure it needs. After that breath, it measures what happened and basically asks itself, okay, did I hit the target? Was that too much or not enough? And then it automatically adjusts the pressure for the very next breath. It's this incredible breath-by-breath feedback loop. Okay, let's shift gears, because we're about to go from a smart version of normal breathing to something that just completely flips the script. This is APRV, the lung recruiter, and it is a totally different way of thinking about ventilation. Yeah, instead of thinking about breaths going in, APRV is all about holding the lung open almost all the time. This is really a rescue strategy for those super sick, stiff ARDS lungs that just want to collapse. The default state is a high continuous pressure to pop open as many of those little air sacs, the alveoli, as possible, with these really brief moments where the pressure just gets released to let CO2 out. Now, the settings for this can look totally alien at first. You set a high pressure and a low pressure, called P high and P low. But here's the crazy part. You also set a time for each of those pressures. So your T high might be, say, 5 seconds long, while your T low might be just half a second. It forces you to completely abandon the idea of a traditional breath cycle. This right here is the main event in APRV. For that long T-high period, the ventilator is basically just holding a high level of CPAP, continuous positive airway pressure, which physically props the airways open. The whole goal is just to maximize the time the alveoli are open for gas exchange, which can literally be a lifesaver for getting oxygen levels up. And this is the ventilation part. The pressure drops all of a sudden for that super short T-low period, and that allows a rush of CO2 to get out of the lungs. But, and this is the clever part, because the release is so brief, the lungs don't have time to fully collapse. This creates what we call auto-PEEP, where some pressure is intentionally trapped in the lungs, preventing that damaging cycle of collapse and reinflation. And here is a massive, total game-changing benefit. The patient isn't locked out. At any point during that long, high-pressure phase, they can take their own small, spontaneous breaths right on top of it. This makes a huge difference for comfort and can really help clear out even more CO2. All right, if you thought that was weird, buckle up. Our final mode takes things to a level that feels like something out of science fiction. If APRV is upside-down ventilation, then high-frequency oscillatory ventilation, or HFOV, is kind of like not breathing at all. Let's meet the gentle hummer. Just look at that number, 420 breaths a minute. HFO doesn't deliver breaths in any way that we would recognize. It uses this speaker-like diaphragm to just oscillate air back and forth at an unbelievable frequency. It is so fast that you can literally feel the patient's chest humming. And here's the part that'll bake your noodle. While the rate is through the roof, the amount of air moved with each tiny little wiggle is just 1 or 2 milliliters. I mean, that's less than the dead space in your own throat. So how on earth does any oxygen get in or any CO2 get out? The secret is that HFOV's main job is just to maintain a high, constant pressure to keep the lung open, a lot like APRV actually. Those rapid, tiny oscillations then just kind of shuffle the gas back and forth. It creates these complex flow patterns that let oxygen diffuse in and CO2 diffuse out, all without ever really stretching the fragile lung tissue. It is the ultimate lung protective strategy, especially for the most fragile patients like premature babies. Okay, that was a whirlwind tour, wasn't it? We went from smart optimizers to upside-down breathing to gentle hummers. So what's the big picture here? What are we supposed to take away from all this? Well, the really crucial thing to remember is that all these complex modes are just different tools for solving the same basic problems. PRVC is your smart compromiser. It's aiming for stability. APRV is your aggressive recruiter. It's a rescue therapy for lungs that just won't stay open. And HFOV is the ultra-gentle protector for when lungs are so fragile that any normal breath could cause damage. Each one has a very specific job, a specific personality. Because in the end, all this incredible technology is only as good as our ability to use it thoughtfully. These advanced modes, they give us amazing power to customize ventilation for a specific patient, but they also demand that we listen more closely than ever to the feedback we're getting from them. So the real question isn't just which mode is best, but how do we use these tools to truly hear what our patients' lungs need, breath by precious breath?